Hi, everyone. I am Marie Forgy. As mentioned, I'm an OBGYN in Milwaukee, Wisconsin. So I'm going to be talking today about transgender and gender diverse gynecologic care. I have way more slides than I have time to talk about today, but I didn't want to delete any of them since I know you guys get them all sort of printed out or on the app. And so I wanted to keep them included so that way you have time to reference them at home, even if we don't have a chance to talk about them today. So there are going to be some slides that I'm just going to skip through, but I'm happy to talk more about them with anybody on an individual level if you would like. Some of this also, Karen did a wonderful presentation earlier, and so it's going to be a repeat of some of the stuff that she spoke about because our topics overlap, but I know not everybody has gone to the same lectures, so I am going to sort of go through it again. Okay. So as you guys know, healthcare providers have the responsibility to provide quality care to all patients, regardless of their sexual orientation or gender identity. I don't need to tell this group this. My disclosures, I don't have any financial conflicts of interest, but I do want to mention that throughout this document, I'm going to be using the term transgender and gender diverse, but I understand, and we should all understand that this is going to refer to a group of people who have varied communities that exist globally with gender identities and expressions that differ from the gender socially attributed to their sex assigned at birth. So there are going to be other terms that people prefer that we use. So this is just sort of for ease of the presentation. And of course, always trying to be patient-centered when you're speaking to your patients about this. I'm going to be using anatomical terms such as vagina, penis, and uterus, but again, this may not be the preferred terms for your patients. I personally identify as Middle Eastern, cisgendered, straight female, and that of course is going to inform my perspective and any implicit bias. Why is this topic important? Again, this is sort of preaching to the choir in this group. We know that transgender and gender diverse individuals face harassment, discrimination, and rejection within our society. We as healthcare clinicians need to improve our awareness, knowledge, and sensitivity to help our patients who already have inadequate access to, underutilization of, and disparities within the healthcare system. And I want to help give everybody in the room the confidence to feel like they can do this work. Some of the sort of pitfalls I run into with some of my colleagues is they just feel like, oh no, I wasn't trained in this. I don't have the skills to do this work or to help these patients. And really, they're just people. So treat them like people and help them with their needs, and you can do it. So my hope is that once you sort of go through the information, you realize it's not that hard, and that we can all do this. Okay, so this is sort of a good place to look at where are our patients coming from? What is some of their experiences? And so this report from the 2015 U.S. Transgender Survey, these findings revealed a disturbing pattern of mistreatment and discrimination and startling disparities between the transgender people in the survey and the U.S. population as a whole when it comes to some of the most basic elements of life. So finding a job, having a place to live, having access to healthcare, having people in their life that support them. And that, of course, is going to come in with your patients when they walk into your exam room. And so understanding that is super important. There is, there has been historically and continues to be discrimination within the clinical space. So a third of those who saw a healthcare clinician within the past year reported having at least one negative experience. And this could be refusal of treatment, verbally harassed, or physically or sexually assaulted, or having to teach their provider about transgender people in order to get the appropriate care. And not surprisingly, this led to 1/4 of the respondents saying they're not going to go to the clinic because of the treatment that they've either experienced in the past or because of fear of what they may experience. And these numbers are even higher for people of color or people with disabilities. In our own words, my state Medicaid does not cover hormones or surgery. With my very limited income, it's difficult to afford treatment I need and will most likely never be able to have surgery. I was consistently misnamed and misgendered throughout my hospital stay. I passed a kidney stone during that visit. On the standard 1 to 10 pain scale, that's somewhere around a 9, but not having my identity respected, that hurt far more. Multiple medical professionals have misgendered me, denied to me that I was transgender, or tried to persuade me that my trans identity was just a misdiagnosis of something else. They've made jokes at my expense, in front of me, and behind my back. They've also made me feel physically unsafe. I often do not seek medical attention when it is needed because I'm afraid of what harassment or discrimination I may experience in a hospital or clinic setting. So again, while we may all try to do our best, you have to know the history in order to move forward. When I was in college, I had my health insurance list me as male and then denied coverage of my routine pap smear and gynecologic prescription due to my gender. So it's not just what patients are perceiving that's standing in the way of providing quality care. It's also what clinicians are feeling. So a surprising number feel that they don't feel comfortable. So what does that mean? Not comfortable? Does that mean you're just not going to do it? And so I hope that we can all start to feel more comfortable. So what is our role? Our role is to gain knowledge, to gain skills, and to also gain cultural awareness. And just to remember that these individuals are not just your patients, they're your coworkers, they're your people in your community. They could be your boss, it could be all people. So we have to be respectful of that. Things that we're going to talk about today, we're going to go through the trauma-informed care and patient-centered gynecological exam. We're going to talk a little bit about preventative gynecological care and cancer screening. I'm just briefly going to touch on contraceptive management. I know that at this conference that there are going to be many lectures that are going to go over this in depth. And so I'm going to leave that more to some of those other lectures, and I'll just run through that quickly. We're going to talk about common transmasculine GYN complaints, common transfeminine GYN complaints. Okay, trauma-informed care. All right. So what is trauma-informed care? Trauma-informed care is a framework through which clinicians and staff can attempt to foster safety, security, and empowerment as part of their service. It's a holistic approach to care that incorporates both the emotional and physical health of the patients, and it's critical given the high incidence of trauma that's rarely reported to healthcare professionals. So you can't just screen for people who've had trauma in healthcare settings and then only apply trauma-informed care to those people, because you don't know. They're not going to say. And so best practices would say to use this for all your patients. And we'll talk about ways that you can do this. Okay. So, there are 6 key principles to this: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. Okay, I don't know how. Okay, good. You can see this. So how can we do this? So it really starts not in your office, but in the way your staff answers the phone, in the way somebody feels when they're in your waiting room, in the way they feel when they walk up to the desk to check in the way that they're called for their appointment, in the way that your office is set up. What kind of pictures do you have on your walls? What kind of brochures do you have in your office? So it's more than just what you as an individual clinician can do, but more how can we change the whole environment? And so it's important to sort of start with training of your clinical staff. One of the hard things that we had was in talking to our clinical staff, in their efforts to be respectful, they really wanted to use sir, madam, miss, Mr. And so that can be challenging if you have a new patient. It can be challenging to retrain your staff to avoid some of that terminology, because even in their best of interest, and I'll admit, I even struggle too. If I have a patient who is, in their 60s, 70s, I grew up saying, was taught you have to call everyone Mr. and Mrs. So it's really hard for me to avoid those words when talking to a patient, because I'm trying to be respectful. But until you know how that patient identifies, just avoid it. And then you can use whatever terms, the patient feels most comfortable with. So working on getting a more gender neutral clinic name can be part of this. And this is all part of that trauma-informed care. Having clear documentation for your medical record, working on gender neutral restrooms and artwork that can be depicting transgender and gender diverse people. And so this is all about creating that safety space, okay? Then getting to the next principle of trustworthy and transparency, having consistent eye contact with somebody. So not just looking at your computer and typing things in because you really want to get all your notes done, but sort of making it conversational can be helpful. Using a soft, friendly tone of voice. I always try to think of having an anesthesiologist voice. So thinking about how the anesthesiologists speak to a patient as they put my patient to sleep. And that's what I try to mimic when I'm, when I can feel myself getting stressed. That's sort of how I sort of remind myself, just sort of slow down, speak more softly. Remaining up to date with gender affirming language. Even as I was reviewing these slides prior to last night, but prior to giving this presentation, I already noticed places where I was like, oh man, I forgot to change that term. And so, sort of, it's not something you just learn once. You come to this conference and now you know for the next 20 years, probably within the next few months, that something new will be different than what you learned from here. Asking your patients for preferred terms for body parts, refraining from asking questions about a patient's body or identity that doesn't matter for that person's exam. Peer support, always offering to have those connections with your local peer support groups. I'm super lucky in my clinic that I have a social worker who is there. And so that is really helpful to me because she can sort of, spend her time finding all the community resources. And it's not so much of a burden on me to try to find all those resources in addition to keeping up to date with terminology and keeping up to date with some of the medical information. So that's really part of peer support. Having that collaboration and mutuality, always allowing your patients to make their choices. Empowerment, voice, and choice. Again, recognizing that some non-traditional lifestyles are going to be part of what your patients are doing and how they're living. And so asking those questions or talking to your patients in a non-judgmental manner is important. Maybe not everybody who has an open relationship feels cheated on. That might be okay for that couple. And so that doesn't mean you have to save them. That might be okay. And so being open so that way people will talk to you about their relationships and let you know whether they're feeling safe or unsafe. They're not going to tell you about their relationships, their safety within their relationships if they don't feel safe with you. And then, of course, as we talked about, sort of having the knowledge of the historical attempts that have been barriers to care in the past, not only historical, but currently. We've talked in other lectures about, legislation that's sort of, in the news every day, groups that are in the news every day that are actively trying to prevent people from getting the care that they need. And so what does this look like? So what this looks like, of course, is lots of work. This is what this looks like in training your staff and getting your clinic name in creating the space. What does it look like when the patient comes into the office? What it looks like is when I have a patient on my schedule, I will sometimes, and they're new to me, if I notice it in advance, I'll call them in advance and say, hey, just saw that you're on my schedule. It's our first time meeting. What are your goals for that appointment? Do you have someone who's going to be coming with you? Just so you know, you can bring somebody with you if that's going to make you feel more comfortable. If they're coming to me, for example, for an annual gynecological exam, perhaps it's their first time having a speculum exam or having a pap smear, letting them know that we may or may not do that at that exam, that it's okay. And that I think helps people understand that they have choice and make decisions even before they walk in the door. A lot of people come through the door totally scared that I'm going to walk in, tell them to get undressed and jam a cold metal speculum in their vagina. That might not happen if that's not what you want. So it might be that we just spend that first visit chit-chatting and getting to know each other. It might be the second date that we do that. Or it might be that they're like, no, I'm not going to want to come back for a second visit. I want everything done that day. Okay, now I know. We can have conversations about whether they're going to want to have somebody with them and know that they're welcome to that. Especially with COVID, you know, there were lots of limitations in terms of whether you could bring someone or not to your visit. So a lot of people are still a little confused. And so, you know, letting them know that they can, letting them know that we could just talk and that maybe they're going to want an anti-anxiety medication that I'm happy to prescribe in advance. Or if we're going to do that, you know, make sure you have someone who's going to drive you home after. So sort of walking through some of that in advance can be really helpful. My clinic used to also be called the Women's Health Center. So I would also first call them to apologize for my clinic name and let them know that they are in the right place. And so, again, I'm lucky that I can do that. You might not have the chance to do that in advance. They might not answer. Everyone has cell phone service, depending on where you are in your pay cycle. Or you may just have too great of a patient load to be able to do that. So a lot of this can be done on that first visit too. Does anybody have any other sort of techniques that they use when they're first meeting people that they would like to share? Yeah.
I look at my patient list for the day before we start, and I go out and talk to my front desk staff to let them know, because I don't always have the same person there. So they show them where to look.
Yeah, I think that's really helpful. I do that too. I kind of go through my list and then I, write on there what pronouns are. And so it's a reminder to, they should be looking in the EMR, but in case they're busy or they're not paying attention, even though I would like to think that they are, it's an added reminder, like this person, these are the pronouns that you should use. This name that comes up, make sure you look at the preferred name, not the legal name, can be really helpful. All right. So in thinking about now they're in the office with you, how do you do a trauma-informed gynecological care, gynecological exam? So having them stay dressed when you first meet them, don't have them kind of be undressed right away. Talking to them, getting to know them. I usually start with, hi, my name's Marie Forgy. I go by she, her. This is my preferred name. What would you like me to call you today? And then I make sure that I write that down. I understand you're here for cervical cancer screening. Does that sound right to you? Because maybe that's what they wrote down, but that's not really what they're there for. Okay. Have you ever had this exam? Okay. What are your preferred name? What are your preferred pronouns? And then I have a poster of sort of reproductive structures on the wall. And I say, let's go through these structures and what are your preferred terms for all of these things? Is this a vagina? Is this a front hole? Is this a, you don't want me to say, you just want me to point? And then again, I write it down in my chart. So that way I know the next time, or maybe the next person, I've gone through this, so they don't have to go through that all over again of sort of talking about it, but also being aware that people's preferences may change. So I do try to reevaluate it, every now and then, just to make sure that people are on the same page with the terminology that they use. I always go through the exam, especially if it's their first exam. I kind of talk about what the expectations are for that exam. I show them the speculum in advance. One trick that I always do is I show them the small speculum and then I show them the largest speculum. And I say, these are the different sizes. This is one I would often use, but this is the one I'm going to use for you. So that way they can see that, like, oh, that doesn't look so bad compared to the biggest one. So I feel like that's helpful. And again, it's going to be even if we're doing it or not. I have had patients where we use disposable plastic speculums, so I can let them take it home with them if that's something that they want, just to get more comfortable with the idea of it. Obviously I'm not using that same one again, but it's just practicing on themselves. When we're actually doing the exam, I used to always be like, okay, I'm going to tell you everything that I'm doing. But some people don't like that. So I had to learn to ask, do you want me to tell you everything I'm doing as I'm doing it? Or do you want me just to do it quick and not say anything? And I found that it's actually 50-50. So I was in my attempt to be trauma informed and really be real slow and sort of like tell them each part, that not everybody actually liked that. And that's something also, I have a lot of learners with me. So when I have medical students and they're like trying to be so slow, even in my cisgendered patients, I'm like, you're just making this take longer. Like, this is not any better for them. So, so talking through that. If they are somebody who wants me to sort of talk them through it, I've changed my language instead of, and next I'm going to do this. It's more, the next thing I'd like to do is I'd like to put 2 fingers inside your vagina to feel your uterus and ovaries. Is that okay with you? So that way I'm asking permission. I'm not telling them what I'm going to do. And just that little change is important. And also, why am I doing this? What is the point? It's not that I just, want to feel your vagina. It's that I, want to feel your uterus for this reason. I would like to feel your ovaries for this reason. And if that's not okay with them, then that's not okay. And I really try in my documentation not to say patient refused exam, shared decision-making, discussed with patient, bimanual exam, not done. So it's not declined, it's not refused, it's that we talked about it. And this is what we're going, this is what we decided to do together or not decided to do together. Using lots and lots of lubrication is important. I think that's sort of everything else. Oh, then allowing the patient to get dressed. After they're dressed, I'll poke my head in the room and I'll say, okay, do you want to sort of talk about next steps right now? Or do you just want to get out of here? And do you want me to call you later? And so that can be helpful too, because some people, they're like, what? And they're not going to listen to anything we talk about anyway. So just go on, get out of here. I'll call you later. And then when I call, I say, okay, is this an okay time to talk about it? What if they're out with their friends or at work and it's not an okay time to talk about it? So those are some helpful steps. Does anyone else have any sort of steps that they'd like to share? Some specific considerations. We've talked about this before, using the smaller speculum for people who are assigned female at birth and are on testosterone therapy. The vagina is actually has a lot more atrophy. The tissue is thinner. So we use the smaller speculum. And it's a balance between, because there's not as many cells, like a lot of times that pap smear does come back as insufficient, scant cellularity. So it's a balance between, you want to be more vigorous with your sample collection, but also not too vigorous, because then it's going to hurt and they're going to bleed. And so I never know the balance until the result comes back. And then I go, oh, well, sorry. I wasn't firm enough. And also talking about that in advance, like you might have to come back for this. And if it doesn't come back satisfactory, we can talk about maybe doing some vaginal estrogen in anticipation, just to help make the vagina have that more cellularity that then helps with collecting the pap smear results. If they're assigned male at birth and have had and have a neovagina, as we've talked about in other lectures, that this vagina is now lined with skin. It's usually penile inversion skin or sometimes intestinal tissue. And so neither of those really make really good lubrication. So you have to use lots of lubrication. It's less elastic. And so you can also consider self-swabs for either when you're looking for infections or when you're looking for STIs. They can be urine or self-swabs. You can also consider self-swabs. Not self-swabs, having the patient put the speculum in themselves. So, usually I just put it at the introitus, the vaginal introitus, and say, okay, it's right where it needs to be. My hand is on it, but I'm not going to push. You push my hand. And so we slowly sort of help push it. So that way it's something that they're doing to themselves instead of something that I am doing to them. All right. Preventative care, cancer prevention, going through, it's routine healthcare really depends on what organs they have. So if you perform an organ inventory, that'll help guide you. And again, it's not too complicated. If they have a cervix, they need cervical cancer screening. If they have breasts, they need breast cancer screening. If they don't have those things, they don't need the screening. Okay. So I think that that's easier to think about than like, well, what were they assigned at birth and what do they have now? What do they have a cervix? Yes or no? And you follow the same guidelines for cisgendered assigned female at birth. Still, don't forget to offer HPV vaccines. Still, don't forget to counsel about tobacco cessation. And we really have limited data on HPV rates of the lower genital tract, specifically in those who have a neovagina. We just don't have that much information. But what we do know is that transgender and gender diverse individuals have decreased access to healthcare, and they have higher rates of smoking, and they have insufficient information on screening guidelines. So sometimes I do like to try to catch somebody while they're there. This may be, I don't know if they're going to lose their insurance. I don't know if they're going to come back, you know, so I'd like to get as much done as they feel comfortable with. And so again, as a reminder, these are the guidelines for cervical cancer screening. A word about the HPV screening, you know, it really depends on the lab that you have, and we're going to talk more about that, about whether you can use that as your primary testing method. So there was this great article that sort of talked about the utility of using HPV DNA testing alone in people who were assigned female at birth. And so they had 31 participants, and they compared provider collected using a speculum versus patient collected self swabs of the HPV. And they found that the sensitivity was 71%. So pretty good. The specificity was 98%. So what this means again is that if someone does a self swab and it comes back positive for HPV, it's probably true. If it comes back negative, it's 70% true. And so 70% is not 95, not 100%, but it's still pretty good, especially considering that over 90% of the participants preferred the self-swab collection. So it's, again, it's about shared decision-making. Are you okay if, you know, I sort of think like, if you are going to be so traumatized by a speculum exam or by me collecting the sample that you are not going to do the cervical cancer screening, well, then 70% is better than 0. And so that could be an option. Yeah.
Maybe do that more often, kind of like bid cards versus colonoscopies, because the sensitivity is a little low.
Would I do it more often?
Yeah.
Like to do the screening? That's a good question. That's a great question. There haven't been a study that has looked at that. So I think that, you know, that would be something great to look at. To be honest, personally, I can't do that because my lab doesn't have the right HPV testing. So at first, when I first heard this study, I was like, great, I'm only doing, you know, in my lab, I do, you know, in my patient, in my cisgender patients, I get, you know, I collect the sample, I send it to the lab, and they tell me cytology. And if they're over 30, they automatically do HPV testing. So I was like, great, we do HPV testing. Now I'm just going to order HPV alone on everyone. But the problem is that the HPV testing that's being done is an RNA test, which is not FDA approved to be part of the primary test. So to be used alone, it has to be a DNA test. So you have to look at the test that your lab is doing and see if it's one of the ones that's FDA approved. Now, have I done this? Yeah. But I do kind of tell the patient, like, you know, I had a patient who was young. We're going to be doing a hysterectomy anyway. Like, they're not going to have a cervix in a month. Like, as long as I can just show that it's negative, I can move forward. And I tried 3 times, and every time it came back insufficient. So what am I going to do? So I just was like, fine, I'm just doing HPV, and it's negative. And so we're going to move forward. But that's just something to think about, is what kind of testing your lab does in your clinic. And so then I even looked at so the bottom part is like what my lab actually specifically says is this is not approved for standalone HPV testing. And again, it has to be that standalone for the self swab. Yeah.
Because I was just thinking there, it sounds like you could.
You can. What do you mean by thin prep? Like for cytology?
No, just for doing.
So again, it depends on like what, like when they collect that thin prep, like what are they using? Are they using, like my lab uses Aptima, so I can't use that because it's not been FDA approved for primary screening. So you have to do that HPV with as like a reflux as part of the cytology. You have to have cytology and HPV. Does that make sense? Am I explaining that in a way? Whereas if my lab took that same little liquid and then used, you know, one of these other ones, then I couldn't. Okay, how about if they've had vaginoplasty? And again, we've talked about this before. Do they have to have a GYN exam? You know, we don't know. So again, shared decision-making. Do they have to have a pap smear? Again, we don't know. If they have a neoclitoris that's made by the glands of the penis specifically does harbor HPV more so than the sort of shaft of the penis. And so, you know, if they don't have the glands, you know, I don't know that I would do a pap smear on those patients, but you certainly could have that conversation. And then don't forget to do prostate cancer screening, or, you know, in my case, refer to a family practice person who does prostate screenings. I do not. Okay, how do we prevent endometrial and ovarian cancer? We don't know. We don't know for cisgendered. We don't know for transgender. They're not at any increased risk. So you follow the same guidelines. There was some fear that, okay, if you have testosterone and you're giving more testosterone, that does get aromatized into estradiol. So then are your patients going to have more estradiol? And then if they have more estradiol, does that make them more at risk for endometrial cancer and ovarian cancer? And the answer is no, because while you are having more testosterone, more estrogen from the aromatization of testosterone, you're also suppressing their endogenous estrogen that's being released from the ovary. So, you know, we don't think that there is any increased risk. So you don't have to you don't have to subject your patients to more exams than you would for cisgender patients. Breast cancer screening, if they haven't had top surgery, for your transmasculine patients, you follow the same guidelines. If they have had top surgery, again, shared decision-making, the risk is very, very low of them getting breast cancer. It's similar or lower to to cisgendered men. We don't have cisgendered men going off, you know, doing mammograms all the time. And it can be even more painful because there's not a lot of tissue. And also it might, you know, be traumatic to that patient who doesn't identify as female to have to go to the mammography. But again, it's not zero. So shared decision-making. For trans feminine, again, limited data. There isn't an increased risk of breast cancer in those on estrogen-containing therapy, but there are some guidelines that say if you're over 50 and you've been on feminizing hormones for 5 years, maybe doing screening mammographies every 2 years is not a bad idea. So in looking at the actual rates of breast cancer, so if you look at the gray sort of line bar at the end, that's for cis women. So that's sort of the standard. And then the green right next to them is for cis men. And so when you look at transmasculine, transfeminine patients, you can see that it's significantly lower in either direction compared to cis women, and probably equivalent or maybe slightly higher than in cis men. And so again, that's where that shared decision-making comes in. Contraception, like I said, I'm just gonna breeze through this. If you want to know everything about it, read these 2 articles, and that's what you need to know. I think they're super great articles, and they really kind of cover things that you need to know. You want to have a gender inclusive approach to history taking. This is a good graph. When you first look at it, I think it's like, oh, this makes sense. But then in the end, really, I think what you need to know is what organs do you have and what organs are entering your body? And do they have semen? Is an egg ever going to reach, is a sperm ever going to reach an ovary? And then that's going to help you decide with your contraceptive counseling. Also, how would you feel if that egg, you know, interacted with an oocyte? Maybe it's not the end of the world. Maybe that's what you want. So don't get all excited about prescribing contraception to your transgendered man, because they may want to become pregnant. So try not to put one person's experience on all of your other patients. There are barriers to contraception, just knowing those barriers to make sure that we don't fall into those same pitfalls. Provider lack of knowledge. we found that there's a lack of comfort of patients providing contraception to transmasculine patients. Patients' lack of knowledge. So a lot of patients who are on testosterone therapy, they're not menstruating, so they think, oh, I don't need any contraception. And that's not true. While being on testosterone therapy does lower your rate of pregnancy, it's not zero. And so, and the problem also with that is if you're not menstruating, you don't know when you're ovulating. And so you may become pregnant and be on testosterone therapy and be pregnant and not know it because you're not menstruating. So you don't have that sort of telltale sign until maybe you have some other symptoms. By the time you have other symptoms, well, now you're past the first trimester, you're well into the pregnancy and you've been on testosterone therapy. And that may or may not, it's controversial, have some effects on that growing fetus. So again, patient lack of knowledge, provider lack of knowledge, negative healthcare experiences, and then maybe, patients have your transmasculine patients may have a bias against estrogen or progesterone containing therapy. It might be triggering to them to carry a little pink pill pack around with them. And so having those conversations with patients to make sure that you're offering contraception that works well with what their goals are and what their barriers are. We sort of talked about that too. We have limited data, but we just sort of extrapolate. We don't think that testosterone therapy has any effect on the effectiveness of contraception. We also don't think that any of the estrogen or progesterone in contraception has any effect on the testosterone that they're getting. So there's not enough estrogen in those pills to really cause a feminizing effect or to undo the testosterone that they're getting. But again, you might have to think about the psychosocial component and then use this table, what I'll say about this, and sort of thinking about things that your patients may be thinking about. Are they going to need an invasive procedure? Does it contain estrogen? Does it contain progesterone? What's the risk for spotting or bleeding? What's the risk of cramping? How does it affect chest tenderness? How easy is it to conceal? Is it going to be something that they have to come into the clinic and get all the time? Is it something that you can give them a year's worth and they just cannot come back? And that might be something you want. And how effective is it? Okay. So common transmasculine complaints. Vaginal bleeding is the most common complaint. So some of the ways to sort of combat this is either spotting while they've already been on gender affirming hormones, or maybe they're not on gender affirming hormones, but they don't want a menses. And so dealing with both of those spectrums, it can be helpful to start gender affirming hormones on the first day of their menstrual cycle, because that's when the endometrial lining is the thinnest. And so that might help kind of decrease some of that bleeding as they're going through their therapy. It may also be helpful to sort of start them prophylactically on a progesterone therapy to help thin out that lining, because there will be more spotting and bleeding as the testosterone levels kind of get to their therapeutic levels and as the lining of the uterus thins down. Something to think about too, hormones for non-binary is people want to, often will say, well, I want hormone therapy, but I want a little bit less. I don't want it quite that much. But a little bit less testosterone therapy may mean a lot more physical complaints, because you might have enough testosterone to sort of help in some ways, but not enough to help in others. And so you're going to have more of that intermenstrual bleeding for somebody who's on a lower dose of testosterone therapy. So things that would make me more concerned is if they've been on testosterone therapy for 6 months and they're still not amenorrheic, that would make me want to do an evaluation for other causes. Or if they had been amenorrheic, they've been really consistent with their testosterone therapy and now they're having bleeding, that would be concerning to me as well. And I'd work them up the same as I work anybody up with the uterus for abnormal bleeding issues. You may also consider getting a mid-injection serum testosterone level to see if that could be the issue, that maybe their testosterone levels aren't sort of maintaining a high enough level, and that could help you make some changes. Another sort of hard topic, but important topic to broach with your patients is how much adipose tissue they have. So you have aromatization of estrogen and production of estrogen from your ovaries but also from adipose tissue. And so in somebody who has more adipose tissue, they're going to have more estrogen in their body. If you have more estrogen in your body, that's going to thicken the lining of your uterus up. And so then you're going to end up with more bleeding issues. And so having a conversation about, healthy, how that might play into some of the bleeding issues that they have. Treatment depends on etiology. Okay, vaginal discharge. So, in thinking about what testosterone does to the vagina, you get a loss of the epithelial architecture, and you get a loss of the glycogen. And then you also really, it comes down to the stromal and epithelial estrogen receptor expression. So sometimes it can be confusing, like, okay, well, if they're on testosterone therapy and testosterone is aromatase to estrogen, why does my patient have vaginal atrophy? And the answer is because even though they may have normal or not normal, so again, so when I redo these slides, I'll not say normal, I'll say physiological assigned female at birth levels of estrogen. They may have that level of estrogen, but the receptors are lower. And so the vagina specifically isn't being activated by the estrogen in their body. And estrogen produces glycogen in the vagina. Glycogen produces lactobacillus. Lactobacillus produces hydroxy peroxide, which then lowers the pH of the vagina, which then inhibits bacteria. So you can then do the reverse. If you have less estrogen, you have more glycogen, you have less lactobacillus, you have more hydrogen peroxide, you have a higher pH, and you have more bacteria. And then again, when they've done studies on this, they have found that their transgender men on T-therapy have less lactobacillus. So what does this do? It can make patients more susceptible to bacterial vaginosis who are transmasculine on T-therapy, can make them more susceptible to cystitis. And also, not all vaginal discharge is an infection. The number of patients who call me, I have BV, can I get a prescription? How do you know you have BV? So, sort of really evaluating for these other causes. Could it be traumatic irritation? Could it be an STI? Making sure that we look for the cause of your discharge and then accordingly treat for that cause. And that might be treating the atrophy. Things I always tell patients, not all discharge is problematic. Not all vaginas are supposed to smell like roses. It's okay. This might be normal. Pelvic pain, again, sort of thinking about the same pelvic pain issues that you may have for your cisgendered patients, taking a good history, doing a physical exam as needed, doing ultrasounds, doing laboratory testing. So some things to also additionally think about in your transmasculine patients are they're on testosterone therapy that does sort of increase the amount of muscle mass that they have. But at the same time, their postural carriage or their skeletal system is more feminine. And so it's harder for that bone structure, for that skeletal system to carry the weight of the increased muscle mass. And so that's going to lead to posture, to changes in the way their posture is. And it's going to lead to more, and if you have changes in your posture, then that changes how your pelvis carries, like the pelvis is like, I'm very visual with my patients. The pelvic carries all of the weight of your body. It's that bowl that carries that weight. And if that bowl is carrying more muscles, you may end up with more pelvic pain. So not all pelvic pain is your uterus or your ovaries. It could be that bowl of muscles. It could be those muscles themselves. And so doing an evaluation and talking to your patients about that can be helpful. And then, of course, looking for other causes, STIs, PID, dysmenorrhea, endometriosis, ovarian cysts, fibroids, adhesions, and then we talked about the musculoskeletal disorders. There's also this sort of phenomenon of patients who are on testosterone, they get this cyclic pain, pelvic pain. And unfortunately, we know it happens, but we don't know why or what to do about it. And if anyone has any more sort of scientific information to share with me, I would love it. I looked again to see if there were any new studies on this that I could share with you, and I have not found anything great. But we do know what happens. So again, getting that sort of trying to figure out how does this cyclic pain happen in relation to their testosterone administration? Why does it happen? We do know that the myometrium, which is the muscle of the uterus, does have more androgen receptors. So maybe that's related, but again, we don't really know. And so sort of having that trauma-informed care, sort of to thinking about that, thinking about pelvic floor therapy, thinking about vaginal lubrication, and also sort of other ways of treating chronic pelvic pain. Thinking about co-occurring mental health conditions, we know that we all carry trauma at different places in our body, in our physical body, and sometimes that's in our pelvis. And so working through that as a possibility, but not saying to every patient who's trans who walks in your door and says, oh, you're trans, you must have a lot of PTSD. We don't even need to do an exam. Go see a psychiatrist. That's not really going to make your patient feel really good, but having that as part of your differential is important. And then treatment depends on the cause. Okay, trans feminine. You know, again, we just don't know a lot about the neovaginal microbiome. And so what's going to cause this vaginal discharge in your trans feminine patients with a neovagina? You know, what we do know is that the neovagina is this vacant niche. And so the type of bacteria that are going to grow are going to be whatever is neighboring. So what's neighboring? The GI system. What's neighboring? The urinary system. So you're going to get those types of bacteria inside the vagina that you may not get in a cisgendered vagina. So things like E. coli are going to be in higher prevalence. And that doesn't mean it's pathologic. That just means that might be what's growing in there. Know that the pH is higher and that there's less lactobacillus, but we don't know what does that mean. We don't know if that leads, what that leads to. So there's a lot that we don't know. We also don't know, you know, you would think like, okay, the pH is higher, there's not as much lactobacillus. What if we gave them vaginal estrogen? Would this increase the lactobacillus and therefore reduce the pH? Yeah, it might, but does that help with their symptoms? We don't know the answer to that. So one of my calls to action is to get more research so we can answer these questions. Okay. Not all discharge is infections, so look for other things. We talked earlier about how if someone has a neovagina that's made from the sigmoid colon, that you can get diversion neovaginitis. And so you can get this inflammatory condition. And so you can see there is sort of a vascularization from a normal neovagina, and then it can get worse and worse and worse and worse. And you're not going to know unless you look, or unless you have the person who's doing the colonoscopy also take a look with a scope, and that could be the cause. Other causes of pelvic pain in your trans feminine patients: tucking, if they've been tucking a lot, sort of thinking about how long are they tucking. You know, could that be leading to pelvic pain? If they have penile atrophy and end up with sort of what's called a buried penis, that could be particularly painful. We talked about changes in the muscle mass, and then also GI dysmotility. Sometimes I tell my patients, I'm sorry you're having pelvic pain. My job is as a gynecologist is to figure out if it's related to your gynecological structures. If I rule those out, I may not have an answer. But that doesn't mean you're not having pain. It just means that I'm not the person who can help you. Thinking about post-surgical issues, sort of, you know, immediate post-surgical issues, wound hematoma, wound breakdown, or if they have a neoclitoris, looking at wound dehiscence. You can have residual erectile tissue too if the erectile bodies from the corpus cavernosa aren't completely excised. And so then when the patient gets aroused, you get sort of erectile or sort of engorgement of these, of this tissue, and that can be particularly painful. Pain with dilation is super common. And so starting from the very beginning, if you have a neovagina, you've got to dilate, and you've got to dilate from the very beginning. Sort of the body treats a neovagina as a wound, and it'll sort of attempt to kind of heal it over with scar tissue and kind of go back to its original muscle memory. And so this is something you just have to be really diligent about. Understanding what prohibits dilation can be important if you want to be able to sort of help patients do it more regularly. So my call to action is to hope that you guys all work on clinical environments, to work on publishing comprehensive guidelines for practicing providers, to help educate trainees. As we've said many times in this conference, you know, our new learners are our future, our children are our future. And so hopefully they can do a better job than we've done thus far. And that we need more research, patient-centered research, to help better inform us on how to improve the lives of our transgender and gender diverse patients. Thank you. Questions?
Do you ever do HPV co-testing instead of cytology with reflex to HPV in trans men under 30, knowing their risk of insufficient sample is higher while on testosterone?
I don't, unless I have a patient who I've already been unsuccessful with the cytology. Luckily, in my, you know, even though we talk about that higher risk of getting an insufficient sample, it's only happened to me once or twice. So I'm usually pretty good at being able to get that sample. And so, you know, that might be something I'd consider if we've gotten scant cellularity and now we're on, you know, attempt number 2 or attempt number 3. Again, just because I don't have any guidelines as to how to interpret that data.
A transgender man stable with therapeutic testosterone levels for greater than 18 months is starting to note intermittent spotting. What would be your first avenue in working this up?
Having them come talk to me and sort of talking about, how are they doing with their testosterone therapy? Is it something that they're getting regularly? Have there been gaps in getting care? Because most of the time it's not a pathological cause. Most of the time it's not a pathological part of the endometrium. It's most often a testosterone issue or a dosing issue, and sort of talking to people about that. But if they are on their T therapy and they haven't missed any doses, and they're in physiologically therapeutic levels, and they're happy with the changes that they're getting to their body on their T therapy, so they don't necessarily want to go up higher to get rid of this bleeding, you know, then I'm going to start to do an evaluation.
If that evaluation is sort of unremarkable, nothing pathologic is coming up, and you say, well, one of the ways that we could, you know, get rid of this would be we could put it in an IUD. I've had patients ask me before, well, I don't want the progesterone containing IUD, I want copper IUD. And so previously I had counseled patients saying, well, you know, in cisgender folks, I'll tell them that it can make their bleeding heavier. But at the recent WPATH conference, there were some gynecologists who were saying, you know, if they're already amenorrheic, the likelihood that the copper is going to then start causing them to have these heavy periods is not. Has that been your?
Yeah, that's been my experience as well. So if this is now a different patient who's not having the spotting, like if someone is having spotting, I'm not going to then put in a copper IUD, because if they're having spot as a means to help with their bleeding, right? Because if they're having spotting, that means their endometrium is thickened, and if their not thickened in an unnatural way, but that there is some endometrial lining, and so putting that copper IUD in is going to irritate the lining and then make it come out and make it more crampy. But if you're using it for contraception solely, then yeah, it can be a great option if someone is amenorrheic from their T therapy.
Any other questions?
Are you doing endometrial biopsies on people who are presenting in center with like the abnormal uterine bleeding after testosterone, and are you doing that before consideration then of like an IUD?
Yes, I am doing them, but that would be after we have ruled all of their other causes out. And if they meet the guidelines for needing an endometrial biopsy, meaning they're over the age of 45, or they have other sources of endogenous estrogen, which in somebody on testosterone therapy is pretty unlikely. So there have been very few patients Obesity is one of those causes. So if they're over the age of 45, then yes. Because, at first we did, the first studies on, hysterectomy uteruses really just showed atrophy, atrophy, atrophy. But some of the newer studies are showing some atrophy, some proliferation. And so because there's proliferation, potentially you do have that risk of endometrial cancer. Is it more than in cisgender? No. So I'm not doing it more aggressively, but I'm certainly not doing it less aggressively.
And then last one on the app, how do you approach pelvic pain in trans feminine patients?
Well, again, you kind of have to go through that whole history and figure out what kind of pain is it? Where is it in their pelvis? When does it happen? What are the triggers? It's really a whole host of things. In my experience, a vast majority of the time, it's been pelvic floor dysfunction, and then working with an amazing pelvic floor therapist is life-changing.
And not that I would expect you to know this, but in trans feminine patients who still have a penis and who report penile pain, which does happen quite a bit, we sort of have asked a group of experts about it, and there's some, again, anecdote, not anecdata, that actually it might be due to the erectile tissue just isn't being used as often. So people have actually recommended therapeutic masturbation that may help a little bit with that penile pain.
Yeah.
Excellent. Well, that's it for time, I think, for us. So thank you so much, Dr. Borghi.
Thank
Anyone else have